Coming up on Mayo Clinic Q&A.
If you look up how many people are really waiting for transplant currently, it's close to 110,000 patients who are desperately waiting for a life-saving transplant.
Today on Mayo Clinic Q&A, we'll look at the success of liver transplantation, including the new techniques being used and how continued research is saving lives.
Mayo Clinic Transplant Program in the 3 site has performed more than 1,600 solid organ transplant and clearly the largest transplant provider in the nation.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. With the goal of shortening the time for solid organ transplants, Mayo Clinic is leading efforts to expand the donor pool by making more organs suitable for transplantation. A Mayo Clinic study previously found that livers from donors exposed to hepatitis C could safely be transplanted. Now that research is expanding to other solid organs. These studies have been the first of their kind in the United States. And joining us to discuss this today is the medical director of the Liver Transplant Center at Mayo Clinic in Arizona, Dr. Bashar Aqel. Thanks for being here today, Bashar.
Thank you. Thank you so much for inviting me, and I'm happy to help with the questions related to this topic.
Well, I am very excited to learn about this today because I remember the mantra not so many years ago when I was being trained that you didn't transplant organs from individuals with hepatitis C. So how amazing.
Yeah, it has been an amazing time. As you know, when we do have such a growing demand, we look into options to help our patients, and seems to be that is an organ pool that very usable, and it has helped to save so many lives.
Well, we will get back to that. But Bashar, first, could you explain to our listeners why is there a shortage of organs to transplant and why is there such a great demand?
A very good question. I would say 2020, despite being the COVID-19 pandemic year, surprisingly, it was a record year for solid organ transplant. 33 lives were saved using transplants from deceased donors during that year. Despite those record numbers, if you look up how many people are really waiting for transplant currently, it's close to 110,000 patients who are desperately waiting for a life-saving transplant. So you can see the disparity between the demand and the solid organ transplant availability, which is really a very critical challenge if you think about it. Why? Because now patients are waiting longer to get their transplant. This is really have a significant impact on the health system. The cost of caring for a patient with end organ damage is really high. And of course, and the unfortunate thing, and we hate to see that, I don't like to see any patient dying on the wait list while they are just waiting for a life-saving transplant surgery. So despite we are doing better, it's not enough. So we need to look to other venues in order to improve access to transplant for all those who need it.
Bashar, may I ask is the reason that we have an expanding need for organs to be transplanted because individuals can live longer while waiting, sort of akin to how patients with cancers are living longer than they used to decades ago, or other disease states?
That's exactly the case. We live longer. We tend to have more chronic diseases. Chronic diseases lead to end organ damage. That's one part of why we are needing more organ transplant. But also think about it. Transplant has evolved over the past several years. Many years ago, if somebody has a liver cancer, that transplant was not an option. Now we can see liver transplant as a curative option for patients with liver cancer. And the same applies with other end organ damage or patients with end organ disease. Same way with kidney transplant, with the kidney disease. People used to stay on dialysis and that was the only treatment option. Now we are becoming more aware that being on dialysis for many years is something that has an impact on our health. So more patients are becoming candidate for kidney transplant. So the demand is higher as our population age, but also the indications for transplant has expanded because we discovered that transplant can deliver better results than the current standard therapy.
That's a great explanation. Thank you. Can you tell me some of the reasons why an organ might typically not be considered a candidate to be transplanted?
Yes, absolutely. Now, just kind of like an introduction to in order for the transplant community, in order to meet the demand, the increasing demand for organ transplant, we have been exploring venues and including live donor transplantation. You know, a lot of us have heard about somebody donating their kidney to their loved one,
Yes,
or donating part of their liver to a loved one. And this is great. And we would like to continue doing this. And Mayo Clinic has been really leading the pathway for a living donor organ transplant. But still, this is not enough. And with that in mind, we start to look at other options. We are looking at the donor pool currently, and we were trying to understand why certain organs were declined. And if you look at the general categories why organs are declined, usually come under some group of patients or some group of donors where people were very concerned about the outcome of using those organs. This includes donors or organs from donors with increased age, donors with certain types of infection that the recipients will get the infection and whether we would be able to treat the infection after transplant successfully. Donors who, for example, in the kidney transplant literature, people were shy using kidney donor or kidneys from donors with an acute kidney injury. Or if you're using donors from patients with elevated body mass index or obesity, because they thought that this may not do it as well. And so those are the general really categories that made us at least limit our use of the organs from donors falling under those groups.
Interesting. When you mentioned the donations to others, I happened to think of some articles that I've seen recently where they talked about sort of chain donations where someone would give a kidney and someone else would give a kidney until the person who was the original person was able to get a kidney. It was kind of long chains, like 16 people or something. It was amazing.
Oh, that's correct. I mean, this is why transplant is all about innovation. When you have a limited pool, you try your best to utilize that pool to achieve the best outcomes. And the chain donation is exactly a perfect example, because think about if I want to donate a kidney to my loved one, I'm not a match, but there's somebody else in New York who really wants to donate their kidney to a loved one, and also they are not a match, but we can match the kidney that I donate to the other donor. Then that can start a chain reaction that allow all those organs to be transplanted in a timely manner and save so many lives.
Bashar, speaking of matching, I'm hoping you can clarify something for both myself and our listeners. When we talk about organs being a match for a recipient, is it just blood type you're looking at, or there's tissue typing, and does it matter by the type of organ?
Correct. Excellent question. It really differs, and it is really determined according to the organ. Okay. Based on my expertise in the field of liver transplant, I can tell you the liver transplant is one of the organs that less immunogenic, meaning for the match in the setting of a liver transplant, we are looking at a match with the blood type and blood type only. Of course, that changed when we're talking about kidney transplant, where we need higher level of match, and the same way applies to a heart transplant or a lung transplant. So it varies according to the organ, but in addition to the blood type, some other levels of matching may be required in other solid organ transplantation.
We started this out by talking about the suitability of organs from donors who might have been exposed to hepatitis C. What is hepatitis C?
Well, hepatitis C, most people have heard about it. You hear a lot of ads on TV, but hepatitis C simply is this virus. This virus that usually we call it a blood-borne pathogen. It's a virus that we will get infected with when we are exposed to contaminated blood products. And the other common risk factor for this, we see chronic hepatitis C in people who really experiments with drug use, whether it is IV drug use or inhalational drug, recreational drug use. So what happens? This virus is a virus that causes chronic infection. causes chronic damage to the liver. And over years, this chronic hepatitis C can progress to liver cirrhosis and liver failure. Interestingly enough, up to 10 years ago, the leading cause where we're doing liver transplant was chronic hepatitis C.
That's what I had thought, yes.
With the breakthrough in medicine and the availability of new drugs or a new group of drugs called direct-acting antiviral agents, those drugs, when became available, they helped us achieve some impressive cure rates of hepatitis C in excess of 95%.
Wow.
Anybody who dealt with liver disease knew that 10 years ago this really was something we never dreamed of, because we were treating our patients for hepatitis C with injectable therapy, almost with a therapy close to a chemotherapy. We treat them for 1 year, and barely we were able to cure 10% of those patients. Fast forward with those new drugs, it's a pill form, well tolerated. It's almost like taking an antibiotic. You take it once a day, you take it for 8 weeks or 12 weeks, so only 2 months and 3 months, and really the cure rate in excess of 95%, and some of the studies up to 99%. So with that in mind, that has helped us to eradicate hepatitis C to the degree now we have several months during the year where we have no patient on the list with chronic hepatitis C.
Isn't that amazing? How wonderful. We always talk about the incredible things that have happened in the time of COVID, but there's a lot of other great medical work going on too. That's amazing.
Absolutely.
So tell our listeners a little bit about the work that you have done on organ transplantation and hepatitis C.
Okay, well, and that's a good introduction really for the reason why we are having that discussion today. Now, as you recall, we just discussed that hepatitis C now is easily treated and it's almost eradicated. So if I see any patient today with hepatitis C and put them on treatment, I have a very high level of confidence that I will cure them from hepatitis C. Unfortunately, and I know we are dealing with the COVID-19 pandemic, but we should not forget that we are dealing with another pandemic, which is the opioid epidemic. And the opioid epidemic is simply where we have the younger generation where they were losing their lives. So many of the young people losing their lives because of drug overdose. And this population tend to have risk factors that put them at increased risk for hepatitis C, which simply means that we have a lot of young people unfortunately losing their life because of the opioid epidemic, and unfortunately are carrying the hepatitis C virus that they have been exposed to just recently without any significant damage to any of those organs.
Okay. But also haven't been treated for the hepatitis C, obviously.
Exactly. We have not seen them to be treated, and they lose their lives, and their families, though going through very tough times because of their loss, they still want to have their loved ones become organ donors. Now, in the past, we used to allocate organs from somebody with hepatitis C to anybody with hepatitis C on the transplant list. As I said previously, we barely have any, and sometimes we don't have anybody on the list with hepatitis C. Because of that, a lot of good quality organs were just thrown away and were not used when we were just seeing more and more patients on the list not making it and losing their life before they get the life-saving transplant that they need. So that really triggered some thoughts. How can we expand the donor pool safely and without affecting the outcome of transplant for the patients who needs it? The availability of the treatment for hepatitis C allowed us to be very effective in utilizing those organs. And the reason why I'm saying that, because we thought about it, if we can have this organ allocated to somebody who needs it on the transplant list, we have an effective treatment that's well tolerated. We can treat them after transplant. And with this, we will have a win-win situation. We use an organ that would have otherwise been thrown away. We allocated somebody who was in dire need for transplant. We treated them and we achieved the cure and achieved a very good outcome for those patients. And that's really what triggered our research in the utilization of organs from donors with hepatitis C.
That really is amazing, because when I hear about something like that, as a physician and as a scientist, I think, wow, that took a lot of guts to think about doing that and then to implement it. And I know that there's a lot that goes into prep for that, into figuring out and calculating whether that really could be successful. But that really is amazing.
And I will say we had all that discussion ahead of starting any of that. And I will share with you that our protocol, before it was implemented, we went through the ethics committee, because you remember there's a lot of that patients hear that we are giving them hepatitis C, and immediately comes a thought, why you are giving me an infection that used to cause people to have liver cancer and cirrhosis? And we wanted to make sure we are doing it correctly. We went through the ethics committee, we went through the institutional review board for research. We made sure that we talked to our patients about the process. We made sure that everybody had a consent form. We put all the guarantees in place so that once the hepatitis C is there, that the treatment will be initiated promptly without any delay. And that's the reason we have been successful so far.
So tell us what you've seen.
Well, I would just kind of like to divide the organs coming from a donor with hepatitis C into two groups. We have the liver, which is usually the reservoir. As I mentioned before, hepatitis C is a chronic virus that infects the liver. So the liver tends to have the highest amount of the virus in our body. And then so there's the liver transplant, and there is non-liver organ transplant coming from a donor with hepatitis C. So starting with the liver, I will say the one thing about Mayo Transplant Center. We think of ourselves as one transplant center that's present in 3 sites. I'm sure that a lot of the people who are attending this podcast know that Mayo Clinic Transplant Program in the 3 sites has performed more than 1,600 solid organ transplant, and clearly the largest transplant provider in the nation. With that in mind, when we put our force together, we're able to get research done it timely, and do it well. So starting with the liver, we got together all 3 sites. We put this protocol together. We made sure we have all the safety measures in place. And we started approaching our patients on the list, whether they would be willing to accept a liver from hepatitis C or not. Surprisingly, within 3 months, we have impressive results. The patient got transplanted in amazingly short wait time. They got great quality livers, and they were treated and they were cured from hepatitis C. 5 patients into the process, we said, really, this is looking impressive. We should just expand that. And we reach out to our institutional review board, and we make it a standard practice across the institution. Yeah. So with that in mind, we were able to help more and more patients. And fast forward, up to more than 50 liver transplants have been done under protocol. Patients were transplanted at a record time, and with a median wait time of less than 100 days, compared to the fact that people waiting for a liver transplant can wait between 1 to 3 years. The quality of the livers they received was impressive. We treated everybody after transplant, everybody was cured. We took that to the second level. I reached out to some of the patients, kind of like in a survey, just a survey, and asking them, with all that in mind, would you have done it once again? Everybody said, absolutely yes, because the treatment was easy, did not interact with any of their medications, was well tolerated, and achieved that cure that we are looking for. So that was a very great success story for our work in the setting of liver transplant using hepatitis C organs, and was really recognized and was published in one of the prestigious journals for hepatology. It's called Journal of Hepatology, just in 2021. It was a collaborative work across the 3 sites. We helped so many patients, and the outcomes have been impressive.
That's amazing, because what had occurred to me to wonder was, we think of someone after they've had a liver transplant as being immune compromised, because they have to be on medications so their body will tolerate, I guess, a foreign a foreign liver that isn't theirs originally. And so I wondered if that would affect the treatment for hepatitis C, but apparently not.
Yeah, it does not. And that's only, that's one of the reasons why we decided to pursue that protocol, because we know that the treatment for hepatitis C does work after transplant. It does not interact with the anti-rejection medication, and it is as effective whether your immune system is compromised or not. So those were requirements for us to consider this, and clearly it is the case.
Wow, that's amazing. What did you find out about other organs?
Very good question. In other organs, the success story was exactly the same, and we were able to expand that to kidney transplant, heart transplant, and lung transplant. Within the past few years, we have been able to do close to 150 kidney transplants, 25 heart and lung transplants using organs from donors with hepatitis C. Once again, we had in place a treatment protocol. We treat them immediately after transplant. Treatment was well tolerated, and everybody was cured from the infection. So more than 200 lives saved with organ transplant from donors with hepatitis C, and everybody has achieved the outcome that we are looking for.
That's amazing. It also sort of speaks to the fact that it's good to go to a center that does things, that has a lot of experience performing certain techniques such as transplants.
I agree completely. And I know a lot of patients, when they come to our center across the board, whether it's in Rochester, Minnesota, or Jackson, Florida, or in Arizona, because, you may know that, but Mayo Clinic transplant programs share the same protocols. Mm-hmm. I mean, the same way we treat a patient for hepatitis C in Arizona, it's the same way that we will treat them in Rochester, Minnesota, or in Jackson, Florida. And so the patients were always shocked to hear, well, what's this talk about hepatitis C organs? And once we explain that to them, everybody wants to be on board. And we have helped so many patients using that organ pool.
Bashar, I am curious because we've been talking about this quite a bit, about inequities, particularly in healthcare, of course, since we work in healthcare. Are there health disparities related to individuals being able to receive organ transplants? And what do we do to work on that?
Yeah, it's a fact, and it has been published. There's clearly some health disparities in access to transplant. It's mainly depending on ethnicity. And so we have seen that there's some lower rates of transplant in Black patients, as well as in patients of Hispanic origin. So those disparities are present, and the Mayo Clinic in general are working to address those issues by our outreach to those populations, make sure every patient gets their fair share in assessment for transplant evaluation, and make sure that those variables are not part of the reason why a patient is really offered a transplant or denied a life-saving organ transplantation.
And I'm wondering if you have found this expansion of telemedicine that we've seen during the COVID pandemic to be helpful in reaching patients.
Absolutely, yes. So this is really what, there's so much negative about the COVID-19 pandemic. One of the positive about the COVID-19 pandemic, it allowed us to understand the power of telehealth. Telehealth is really powerful in a way that when it's used appropriately, it will work for the best for our patients. It allows us to have access to remote areas and to patient population who otherwise were not able to make it to the transplant center in a timely manner. Even I'll take that step further, because it allows us to reach to even certain providers and educate them about the appropriate timing for transplantation and when to send the patient for transplant. And Mayo Clinic has also led the way in this with innovation, to the degree we are able now to do a virtual transplant evaluation for a patient who is really living remotely, and we only bring them here when they are ready for transplant. So wow. Think about it. This would have never happened 2 or 3 years ago.
That's amazing, because there's a lot of testing that goes into evaluating whether someone could have an organ transplant.
Absolutely. And, we try to do a lot of the tests locally, but think about it with the telehealth and the power of the electronic medical record and the ability to share. Yes. A lot of the testing can be uploaded and reviewed by us and by our expert radiologist. And then that allow us to do 90% of a transplant evaluation while the patient is remotely. That have given access to transplant to a lot of patients who otherwise would not have been able to make that trip and get that done.
Bashar, this sounds like absolutely amazing work. What is next? What do you see coming next in the field of solid organ transplantation?
Very good question. And I will just start with first, just an introduction about treating the hepatitis C after transplant.
Yes.
I mentioned the treatment for hepatitis C. It's a pill form. We take it once a day, usually for 12 weeks, and the cure rates are excellent. Now, that 12-week treatment duration, we felt it is long. And in the field of research, you always see what other people are doing. Mm-hmm. We became aware of a group of transplant physicians in Toronto where they have this innovative approach of giving the treatment for hepatitis C immediately before the transplant, hoping that this will neutralize any virus that comes with the organ and maybe allow us to shorten the treatment duration. We looked at the data, it was really convincing, and we decided to adopt a similar protocol. So that really was the basis for an innovative research that we initiated approximately 1 year ago. I led a group of researchers here at Mayo Clinic, and we decided to use the hepatitis C treatment combined with a medication that lowers the cholesterol level. Everybody will ask why you are using this medicine. And the reason behind the use of that medicine, that this medicine in particular, which is really, we use it regularly, we found several years ago that to prevent the hepatitis C virus from getting into our cells. And if you think about organ transplant, if we're putting a new organ in with hepatitis C, if we can prevent the virus from getting into the cells and give the treatment with antiviral therapy, maybe that will give us the best odds of preventing the hepatitis C infection altogether. So we went ahead with this protocol and we used the combination of therapy, just the day of the transplant and for only 7 days. So 7 days compared to 12 weeks. So 1 week compared to 12 weeks. We started that protocol 1 year ago, and our research now will be presented at multiple national and international meetings as the results were impressive. We have so far 31 patients we treated under the protocol. And remember, those patients were transplanted from organs with hepatitis C, but they were non-liver. So those are hearts, lungs, and kidneys. We treated them the day of the transplant and for only 1 week. And so far, we have prevented the infection in 100% of those patients. So the recipients never got hepatitis C. So this has been an innovative approach to treat patients who receive those organs. And a lot of those patients were cured from hepatitis C even before they left the hospital after their transplant.
That is truly phenomenal. 7 days is shorter than many courses of antibiotics that we give patients.
Absolutely. I mean, wow. And the processes, if you think about it, cost effectiveness analysis have been excellent. We eliminated the risk of having hepatitis C virus in the system that could affect our body, even if it is for a limited period of time. And most likely, we would be able to convince a lot of other groups. This is the way to treat patients who receive those organs, and hopefully will enhance the use of those organs more and more, so that more patients will receive the life-saving transplant that they need.
Wow, that is just amazing. I actually really love learning about this from you, Bashar, because I have spent much of my career working on the opioid epidemic and solutions for that. And that's a whole topic for another day, but to see that there is meaning for these families when they lose a loved one, which is so heartbreaking because they're often young people in the prime of their life. But this is wonderful to hear.
Yeah, no doubt, no doubt. I mean, behind every story with transplant, I always say that behind every transplant, there is a story of a family going through the struggle of losing their loved ones, but yet they want to have a meaning by having the organs of their loved ones allocated to somebody who needs them, so that they can help others. So it gives me goosebumps to think about that, but it it's sad that we need to lose that we are losing so many lives. But I feel there's a meaning for that loss once at least the organs are used to save somebody else's life.
Yeah, what generosity of spirit to be able to think of those in need when someone is suffering such tremendous grief within their own family. That really is neat.
I agree.
Anything else you'd like to share today, Bashar, with our listeners?
Nothing. I think we have a lot of work to do. I mean, Mayo Clinic, the transplant program continues to pursue innovation to help more and more patients. This is one way we can help patients. We are working on a preemptive Hep C treatment in those who receive a liver transplant. That work in progress, and hopefully will be the discussion for at a different time. But there's a lot of promising work. We will continue to work hard. We know there are a lot of people who need transplant, and we will not stop short until all the people on the transplant list get the life-saving surgery of a transplant that they need.
Well, wonderful. Please come back and tell us when you learn more.
Absolutely.
Thanks so much for being here, Bashar.
Thank you so much.
It has been our absolute privilege today to have the medical director of the Liver Transplant Program at Mayo Clinic in Arizona, Dr. Bashar Aqel, here to talk to us about solid organ transplants when the donors have been exposed to hepatitis C. What a fascinating and meaningful topic. I hope that you learned something. I know that I did, and we wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.